some people come in. 1 or 2 minutes, right? Okay, thanks. Ladies and gentlemen, everyone who is physically here in the room, and everybody who is following us online, welcome to this session about what are we learning about self-injection. The presenter are available here in the room. Me, the moderator, my name is Kostas Daishimie. I'm a researcher and working with the Jagiellonian University Medical College in Poland. So I welcome you again to this session about what are we learning about self-injection. Self-injection, contraceptive self-injection, is a new self-care practice with the potential to transform people's family planning access by putting injectable contraceptives directly into the hands of users. The researchers have shown that SI injection is feasible and accessible. However, evidence regarding how to design and implement SI programs under the real-world condition is still needed. Ladies and gentlemen, for today's session, our presenters are going to take us through all this evidence that we need to implement SI programs. Our amazing presenters today, they are going to tell us about possible barriers, facilitators, biases, and opportunities of self-injection programs in different parts of the world. And finally, they will tell us about what is the real experience, how they are being used to promote the contraceptives in respective countries they represent and the organization they work with. Ladies and gentlemen, without taking too much time, let me introduce our first presentation. Our first presenter is a senior public health expert working with the Clinton Health Access Initiative. She has over 15 years of experience in sub-Saharan Africa in this field, working with different countries. Ladies and gentlemen, please welcome Mrs. Getam Bitam. Miss, please, Getam, please.
Good morning, everyone. Yeah, so I will be sharing the findings from the study that we did in Malawi, titled Barriers and Enablers of Switching to DMPSC Self-Injection Among Current Injectable Contraceptive Users. So this is a collaborative work between the Malawi Ministry of Health, Reproductive Health Directorate, and the Clinton Health Access Initiative. Just to give you a little bit of background about injectable contraceptives in Malawi. So injectable contraceptives in general are the predominant methods, actually accounting over 50% of contraceptive users. The MPSC was introduced in Malawi in 2018 as both provider-administered and self-injection. And by end of 2020, we will have almost achieved national scale-up of self-injection. So there is a lot of evidence gathered in Malawi showing the acceptability and feasibility of the MPSC self-injection. However, when we started rolling out, the uptake of self-injection was not as high as we saw in the feasibility studies that was done, which really underscored the importance of generating more evidence on the barriers and enablers for uptake of self-injection among current injectable users. So we wanted to answer, or explore these barriers and enablers along the client's behavioral change journey toward the self-injection by focusing on the factors that you see here in this slide related to awareness and perception, access, training and initiation of self-injection, storage practices, reinjection, the factors related to reinjection, disposal, and continuation of use. So we have tried to answer these questions that you see on the screen by exploring these factors. So this was a cross-sectional qualitative study done in 6 public facilities in Malawi, randomly selected, in 3 randomly selected districts. We worked with 2 study populations, especially for this research question. Sorry, my screen was covered. Our first study population group is women who are receiving injection from the providers, either for DMPSC provider administration or DMP-IM. And the second study population is women who are receiving self-injection in the past 9 months, or women who were doing self-injection. So we did in-depth interviews with both study groups, but we also had 2 videos which we showed to the women. One of the videos was showing women a kind of a best practice counseling video to help them compare their practices or their experiences when they had the interaction with the providers. The other video was shown to self-injection clients. It's a self-injection training video, a path video actually, to also help them appraise their experience of receiving training. We did data collection in October, and then it was analyzed using the DDoS software. And we also did validation workshops in 2 districts in February. To take you through the results, these are our participant characteristics. I will just focus on the popular ones. So most of our women were married women. We had IM users, provider administered DMPSC users. We also had self-injection users in the mix. So most of our DMP-IM or injectable provider users have heard about DMPSC self-injection. And as you can imagine, almost all of the self-injection users are aware of self-injection. Going to the meat. So these are the factors that affect a woman's decision to take up self-injection and also for its continued use as well. So we have highlighted the critical factors involved for the sake of time. So in terms of awareness and perception, most of the women we interviewed really appreciated the reduced facility visits that come with self-injection. They said it's convenient and also it gives them some discretion and privacy. However, almost all of them said that they had fears at first because they thought it's going to be painful, and also they doubted their abilities to do the self-injection by themselves. In terms of access, I think the prominent factor here is access to contraceptives. We had a lot of stockouts, as everyone else. So stockouts have been a challenge for women in terms of especially affecting the initial decision for uptake of self-injection. Not just stockouts, having a commodity with a short shelf life is also another factor because it affected the provider's decision to provide more doses for take-home. On training, so the experience of most self-injection users is that they were able to receive a more longer comprehensive training, self-injection training. They also said that they had the opportunity to hear from satisfied clients' experiences, other women who had a good experience about self-injection. And also, they also had opportunities to practice self-injection and do demonstrations, and even have the opportunity to do retraining whenever they were not able to do it right the first time. However, on the contrary, most of the provider-administered clients said that they felt their providers seemed to be very busy and rushing everything. They said they didn't have opportunities for practice, demonstrations, or even retraining. In terms of storage, most of the self-injection clients also said that they didn't have problems with storage. They were able to find a safe storage space, but also they recognized the contribution of their partners. Most of them said they had a good support from their partners, so they didn't have to worry about where to store the product. We had a few clients who were concerned about where to store the commodity and saying that that also affected their decision to uptake self-injection. So these were mainly discrete users. On re-injection, so the key factor here is, so most of the self-injection clients, there are some codes which I will show later, but most of the self-injection clients said that they were able to do the self-injection at home, which is the second injection at home, without a problem, competently. On disposal, disposal wasn't really a big factor here, but just to highlight what the women said, most of the women said that they were able to receive clear guidance on disposal. They knew where to dispose it. So they had that advice from the provider. Though after seeing the video, some of them felt like there was a confusion in the messaging from the providers. Continuation, the key factor, as I highlighted earlier, here is stockouts. After initiating self-injection, most of the women had issues getting the refill because the facilities were getting out of stock of the commodity. So these are just some of the quotes from the women. So for example, one of the women, this is what she said when she was asked about what she likes about the self-injection. She said, we come from afar, so they said those who will manage to self-inject will be given 3 doses to use at home for the whole year. I would save costs of traveling. So this is a married woman from one of the districts. The other woman, when she was talking about her initial fears about injecting herself, she said, I had fears at first, but the fears went off because we were self-injecting under direct observation by the provider. They were instructing us on how to do it, and the interviewer asked, how did you deal with the fears? And the woman, she said, it's because of the counseling they gave us. When we started the procedure, everything was going as they had taught us, so this relieved our fears, emphasizing the need for comprehensive counseling to alleviate the fear. This quote is also from another woman who was talking about her experience of the second injection at home after she was taking the home doses. She said at the beginning, we used to be scared, maybe hands was just shaking, but when we found out that the medicine has ended in the tube, and we did it properly without fear the second time. Another last quote from a woman talking about her challenges of continuing self-injection. She said, after using the first Cyana that I was given, I went back to the provider to get other doses, but I was told that Cyana is out of stock. And I came back the other day, and I was told the same thing. Then I later decided that I should just get depot. for me to avoid pregnancy. So this is one of the findings related to switching to other methods because of the stockouts. Just to conclude, I think, as you saw from the previous slides, women really like self-injection because it gives them opportunity to focus on other things. However, we need to understand that there is this fear that's affecting the woman's decision to take up self-injection, though they like the product. So, which emphasizes the need for counseling. Stockouts also affect initial uptake for self-injection. That's also, which also sometimes lead to discontinuation, as we have seen from the quote in the previous slide. Many self-injection clients, they have reported receiving a good comprehensive counseling from their providers, and also they had the experience of hearing from other satisfied clients, which encouraged them to take self-injection, while the provider-administered clients didn't have that opportunity to get the information and the confidence they need to take up self-injection. And also in terms of storage, as we have said, storage for self-injection women, they felt they had a safe space and they had the support from the providers, while we also saw some clients, especially the covert users, have concerns on that. Post-training, this also emphasizes that once women receive the comprehensive, adequate training, they don't have issues doing the self-injection at home after the training. So overall, the main barriers affecting the uptake of self-injection as per this study are stockouts, some cases of rushed or incomplete counseling and training, leading to client confidence, lack of confidence, and also concerns from covert users about safe and private storage space. So these are the recommendations from the study team. We believe that continued national efforts to secure and distribute consistently or to secure and distribute in a consistent supply chain mechanism is really, really important. We have seen that in this study, but also in our experience in the field implementation. And in addition, we have also gaps in training, especially at community healthcare workers level, so it's also important to address the training gap we have. Ensuring that trained providers receive follow-up support to make sure that they can retain their knowledge and skill that they obtained in the training, but also to address some of the things that we saw as gaps in terms of counseling for women. Supply chain is a big problem everywhere, but it needs to be addressed, especially at local level. We also recommend that community sensitization needs to be strengthened, but also the role of men for women who are self-injecting at home is really, really important. They need that support to continue. We also identified some areas to be further explored further. Some clients, there is a mixed finding in terms of having demonstrations, so that needs to be really explored well. Group trainings, we have seen some providers doing the trainings in groups instead of one-to-one, so they have their own reasons. So it's also important to explore whether that's going to work in Malawi or not. Incorporating the experience of self-injection satisfied users, some women felt, they felt relieved when they hear from other fellow women about their positive experience. So that's also something that we want to explore. The role of partners and family members, not as just support system, but also as injectors, because some women also have said that they wanted their husband to do the injection for them. And also some women also mentioned that they wanted their friends and neighbors to do the injection. So we don't have any guideline on that, but this is something also we need to explore. And in Malawi, the community distribution or injection is at now health surveillance assistant level, but we have a lower level cadre, and we also felt that it's important to explore their role. We would like to recognize the contribution of many stakeholders here, RHD, Department of Reproductive Health, for partnering with us in this journey. Our clients, data collectors, providers, PATH International for allowing us to use their resources, and also the CHAI colleagues for their support throughout, and finally for Bill and Melinda Gates Foundation for funding this research. Thank you so much.
Wow. Thank you very much for telling us about the barriers and the facilitators in Marawi. Please join the hand with me and we clap for her for this amazing presentation. Before we do the second presentation, we have a feedback that the online link is not working. Please help us to fix this problem because online participants are not following. So for the next presenter, our second speaker is a program officer with Akena Plus Health. She works on the ICANN project, Innovation for Choice and Autonomy, which is a consortium of researchers from different countries, including Nigeria, Malawi, Kenya, Uganda, and the University of San Francisco in the United States. Ladies and gentlemen, please welcome Miss Aminat Tijani. Please.
Yeah, it's this one, but it's not showing. Yes, you should go back. It's not the beginning. They're trying to open it. Yes. Okay. Okay. Let me see. Okay. Okay. Good morning, everyone. So today I will be taking you through this presentation for our research paper titled How Do Provider Biases and Pro-Social Preferences Affect Service Delivery? Evidence from the implementation of self-injectable contraceptive, or DMPASC, in Lagos, Nigeria. So data collected for our research is part of the ICANN project, Innovation for Choice and Autonomy. And one of the project's objectives in Nigeria is to assess how programs are delivering on DMPASC for self-injection, of course, through the lens of a total market approach. So a bit of background about our research. Provider support is crucial or essential for expanding contraceptive access, but then some healthcare providers may not strictly adhere to clinical recommendations and discretions. So looking at service delivery, there might be two conflicting motivations at play amongst providers in Lagos, Nigeria. On one hand, you have pronatalist belief. Pronatalist meaning these providers encourage women to bear children. And so this belief might discourage premarital sexual activities and restrict FP access, especially amongst young unmarried women. Then on the other hand, providers may feel this sense of pro-social responsibility as frontline health workers. I know I've said pro-sociality, pro-social, so think of it as altruism or selflessness. So they feel this sense of responsibility as frontline workers, where some of them may be willing to give discounts to clients and even accept lower profits from customers who may not be able to afford these products. So which brings us to our important but underexplored research question. How do provider biases and their pro-social preferences interact to affect service delivery, specifically for DMPASC self-injection? So we hypothesized three things. One, providers will be less willing to offer DMPASC for self-injection to young unmarried women relative to older married women with children. Two, providers with stronger pro-social preference or stronger altruism will be more willing to offer the NPASC to young unmarried women. And 3, we anticipate substantial differences in biases and pro-social preference, and also discrepancies between providers' stated and actual behavior. So our methods. So we conducted a series of in-depth interviews amongst providers in Lagos, Nigeria, 31 IDIs to be specific. And we did this to understand the nature and extent of their biases and their pro-social preference. So for provider biases, we measured provider bias using vignettes or case studies, if you will, or case scenarios, if you will, where we asked these providers whether they would offer DMPASC for self-injection to young or married women versus older married women, and any reasons for refusal. Then we measured their pro-social preferences using 2 major altruism questions. So first, we used stated altruism, where we asked providers how willing they were to give to the needy without expecting anything in return. And we asked them to pick on a scale of 0 to 10 how willing they were. 0 meaning they weren't willing at all, 10 meaning they were very willing. Then we also used a hypothetical dictator game, which we adopted from the Global Preference Survey. And we asked providers that should they get an unexpected cash gift of, say, $50, what percentage of that would they give to the needy? And just to digress a bit, to give you an highlight about what the Global Preference Survey is. So the Global Preference Survey is an experimentally validated survey module used for measuring things like altruism, risk aversion, and other micro-level human behavior. And it has been used across 76 countries. So we adopted the hypothetical dictator game as a measure of pro-social preference from this survey. So moving along, we also measured domain-specific pro-sociality, and this was mostly targeted at providers who sold the NPASC, which is largely in the private sector, as in the public sector it's free. So we asked these providers how they will handle needy clients who couldn't afford the NPASC for self-injection, and also whether or not they would offer discounts to such needy clients. Then we had the mystery client interactions. So where mystery clients corresponded with either of these 2 profiles, either they were going in as young or married women or older married women with children. So they were going to these providers to seek the NPASC for self-injection. And so we measured whether or not the providers offered the NPASC for self-injection to these MC actors. And we also measured MC actors' reported experience on quality of care, including whether or not they felt mistreated or misjudged based on their profile. And so after the visits, the MC actors used survey questions to report their interactions. So our data analysis. So we did a descriptive statistic stratifying on provider, gender, and sector vis-a-vis public-private sector. We compared providers' stated preferences from the in-depth interview against their actual behavior from the mystery clients. We calculated discrepancies between the provider's stated preference and their actual behavior. And lastly, we estimated linear regression models to assess the association between providers' pro-social preferences and stated preferences from the in-depth interview, and the providers' pro-social preferences and actual behavior from the mystery client visits. Our results. So looking at provider demography by gender and sector, on the left we see for gender, we had 73% of the providers interviewed were female providers compared to the male. And on sector, over 50% of providers were from the private sector compared to the public sector. And just to add that for the public sector, providers were mostly from primary health centers and community-based distributors. And for the private sector, providers were PPMVs, patent medicine vendors, and pharmacists. So on comparing providers' stated preference and actual preferences, looking at the chart above, we saw that providers are generally willing to offer DMPA-SC for SI to women, but most stated a higher preference to offer it to older married women. And just to highlight the chart on the right, that 84% of the providers stated more willingness to offer DMPA-SC to older married women versus young unmarried women. But then in contrast, looking at the chart below, we see that most providers did not actually offer DMPA-SC for SI to this mystery client profile. And if you look at the graph chart below, for both profiles, less than 40% of the providers were willing to offer them DMPA-SC for SI. And just to highlight, for the young unmarried women, only 30% of providers were willing to offer this profile, DMPA-SC for self-injection during the mystery clients. So we also saw discrepancies between provider stated behavior and actual behavior. So looking at the chart above, highlighting the young unmarried women, we see that 71% of the providers who said they would dispense DMPA-SC to young unmarried women did not do so during the mystery client visits. And for the older married women, 63% of the providers who said they will dispense did not actually do so during the mystery client visit. We also saw that, looking at the chart below, discrepancies between providers' stated behavior and their actual behavior ran both ways, meaning that providers who stated they will not dispense during the IDIs actually did. And just to highlight, for the young unmarried women, we see that 33% of those who said they will not dispense to young unmarried women actually did during the mystery client visits. So for our regression table, I'm going to run through this. So we're looking at the association between providers' pro-social preference and stated preferences from the IDI. So column 1, starting from the left, shows pro-social preference, whether measured, as I said earlier, either measured as stated altruism or from the hypothetical dictator game. Column 2 shows providers' willingness to offer discounts to needy clients. Column 3 and 4 as a whole represent provider bias. That means their willingness to offer either profile. So assessing column 1 and 2 in row 2, we see a higher altruism was correlated with lower stated willingness to offer discounts to needy clients. What this simply means is that the more altruistic the provider was did not necessarily mean they were willing to offer more discounts to needy clients. And then assessing column 1 and column 3 and 4, we see that altruism was not correlated with stated provider biases. What this means is that altruism was not correlated with providers being more or less willing to offer DMPA-SC to either of these profiles. So looking at our regression table for pro-social preference and actual behavior from the mystery clients interactions now, column 1 still represents pro-social preferences, whether measured as stated altruism or hypothetical dictator game. Column 2 and 3 represents providers' willingness to offer self-injection to either of this profile. And so assessing column 1 and column 3, we see that altruism was not correlated with providers' willingness to offer DMPA-SC to older married women. But then, assessing column 1 and column 2 in row 2, we see there was a positive correlation between altruism and providers' willingness to offer DMPA-SC to young unmarried women. And what this simply means is that the more altruistic the provider, the more willing they were to offer DMPA-SC to this profile, hence the positive correlation. What does all this mean? So we've seen that using provider IDIs, triangulating it with mystery client visits, we've seen evidence of both provider bias and pro-social preference or pro-sociality among providers of DMPA-SC in Lagos, Nigeria. We've seen that from the IDIs, providers stated less willingness to offer DMPA-SC to young unmarried women compared to older married women. But then this gap shrinks when comparing their actual behavior from the mystery client visit. And so these discrepancies reinforce the need to triangulate data across sources. We've seen substantial evidence of altruism amongst providers, where we see altruism positively correlated with providers' actual willingness to offer DMPA-SC for self-injection to young unmarried women. And so what these particular findings suggest that providers' pro-social